It was actually a lot of fun putting the presentation.
So it's my great pleasure today to introduce Dr. Jennifer Barton as our colloquium speaker. Dr. Barton is currently a professor of biomedical engineering, electrical and computer engineering, optical sciences, as well as agriculture and biosystems engineering here at the University of Arizona. She has previously served as the assistant director of the Bio5 Institute. She was the inaugural department head of the of biomedical engineering and chair of the BME graduate interdisciplinary program. She's a fellow of the SPIE as well as a fellow of the American Institute for Medical and Biological Engineering. In 2012, she became our associate vice president for research, and in 2013, she was tapped to be our interim vice president for research. She has over 80 peer-reviewed publications, and today she's going to talk to us about some of her work on endoscopic optical imaging.
Sounds like the microphone is on. Can you all hear me okay? Great. Well, it's my pleasure to give the Optical Sciences Colloquium. It's one of the great honors of being here at the University of Arizona, and a lot of fun. So I want to talk about an area that we've been working on, and actually is an area of excellence here at the University of Arizona, which is in dealing with the problem of ovarian cancer. Cancer in general, I'm showing some statistics up here. And if you look at it, this is for ovarian cancer, but the same trends hold for all types of cancer. If we can catch cancer when it's localized or confines to the primary site, the 5-year survival rate is extremely high. Unfortunately, for ovarian cancer, the number of patients that are caught at that stage is very small. It's much more likely that these patients are detected cancer when it's at the regional or distant areas, and then the 5-year survival rate starts plummeting. So one of the problems with that, with ovarian cancer, is that the ovaries are located deep within the body. You can't see them, so you can't do checks like we all learn to do when we live in Arizona, check ourselves for skin cancer. You simply can't do that. And if you want to do a non-invasive imaging technique like MRI, then you end up with images like this of the whole pelvis, so all the way up from the belly here down to the back. And there are the ovaries. They do show up. There's the 2 ovaries. But you would never be able to detect microscopic cancer with a technique like this. What we'd really like to be able to do is to get a high-resolution technique where we can see very much the details down to really the cellular level, definitely at least to the structural level. So just to summarize that, ovarian cancer, it's not the largest number of new cases diagnosed of all cancers, but it's an extremely bad prognosis. 70% of women who contract ovarian cancer die from that disease. There are some current screening methods. There's a blood test. There's a blood serum marker. Transvaginal ultrasound has been tried, simply palpation or just feeling. And they're not shown, though, to extend life. In large, massive trials they've done with women who have gone through those screening techniques, there was no life saved. So they are ineffective. And you can find things with ultrasound or palpation once they're large. By then, the prognosis is poor. So we really need an early detection method. But it's deep in the body. The cancer symptoms are vague. There's no well-established or precancerous condition, which is the other problem. We just don't know a lot about ovarian cancer because by the time we see it, it's very advanced. So for women who are at high risk, who have maybe BRCA gene mutations, you've probably heard of the breast cancer gene. It is also a high risk factor for ovarian cancer, or have a very strong family history. Ovary removal is really the only effective option. However, removing the ovaries before the date of natural postmenopause can actually shorten life. So it's not really a good option. And of course, it also leads to loss of fertility. I put this up here because we're also discovering that ovarian cancer is maybe not ovarian cancer, at least not in all cases. There's growing evidence that ovarian cancer actually starts in the fallopian tubes. And it's actually because the fallopian tubes brush across the surface of the ovary that it's actually transfer of those malignant cells from the ends of the fallopian tubes onto the ovaries that causes the most lethal forms of ovarian cancer. This is good news and bad news. So the bad news is that we've been looking at the ovary all along, and maybe that's not where we should be looking. Maybe we should be looking at the fallopian tubes. And the fallopian tubes are even more difficult to look at than the ovaries, because at least the ovaries are like little golf balls. The fallopian tubes are floppy, and you have to go inside a tube, and it's more difficult to access. But the good news is that maybe this means that there is a precancerous condition. You know, in skin, you can get these scaly things called actinic keratosis that occur before squamous cell carcinoma. In colon cancer, there's very well-known dysplasia. For cervical cancer, women regularly get pap smears because you can detect dysplasia long before it turns into invasive cancer. So maybe if we start looking in the fallopian tubes, we actually can find a precancerous condition, and maybe that persists for years, and so we actually have some window in order to find it. So that's kind of the good news of this development. So what we really need is something that can give us near cellular level resolution, or at least give us some molecular information that would tell us that a region of tissue is suspicious. And one of the other good news is about this thinking maybe of fallopian tube origin is that it's back being an epithelial cancer. Epithelium being that layer, your skin, the lining of your stomach, the conjunctiva over your eye, that layer, thin layer of tissue that covers all the organs and all the tubes of your body. And so that also means we don't have to look very deep. You know, there was a thought when we were looking for ovarian cancer that maybe it originated deep within the ovary, and that would have been bad for optical techniques. So if we look at the depth of penetration versus resolution, most imaging modalities tend to kind of fall along a line. You basically can get deeper imaging, deeper penetration if you're willing to give up resolution. And so the optical techniques cluster down here, maybe getting up here with some diffuse optical techniques. High-frequency ultrasound and MRI-CT get to be kind of, you know, some whole-body ones, but aren't at the resolution we want. But if we look down here in this area, there's a whole bunch of imaging modalities that might really be very interesting to take a look at, to start seeing precancerous changes in tissue. And as I said, this is an area of excellence here at the University of Arizona because there are 3 imaging modalities that have already been used in vivo in pilot studies, and in the case of Dr. Ratiometric for confocal, some pretty extensive studies have been done. And then one more, holographic imaging, that will be started next year. So there's a whole bunch of ideas that we might have for looking at this problem, and which one's going to end up being the most effective? I guess we'll find out. Will it be a combination of them? Will some modalities be effective for some types of patients and not for others? These are the types of things that need to be worked out, and really what makes this a biomedical optics problem. So all of these techniques have got to be better than what we have today. Even if we do get inside the body, and so we can take a look at the ovaries, which are these white tissues here. There we go, focus. This is a laparoscopic image done through a camera that was placed through a small incision in the abdomen and put into the belly. Again, it might be hard to see any sort of microscopic changes that are occurring either in the ovaries or in the fallopian tubes, which are coming off on either side here of the uterus. So this probably isn't going to help either. So what we currently have right now, even for a minimally invasive technique like laparoscopy, is probably not sufficient. What do we really want? We really want it to be minimally invasive. Even non-invasive would be even better, but with optics that's going to be hard to do because the ovaries are deep and we just can't image that deep. We want it to be high resolution or to provide molecular information. We want it to image at least 100 microns deep. That's good. Probably just about any sort of optical imaging technique can do that. We'd love it to image markers of proliferation. The docs keep asking if we can please image P53, which turns out to be a nuclear marker. You'd have to have a contrast agent that went into the nucleus, which is really not viable for in vivo studies. You really don't like dyes that would go into the nucleus. So that's probably not going to happen. But there are other markers of proliferation, such as epithelial growth factor, vascular growth factor, that have been implicated in other types of cancers, which are cell surface markers. So maybe we can target them. Easily packaged into a small, sterilizable handheld probe, and rapid image acquisition and presentation, which is one thing that optics really shines at these two areas. It's not like MRI that's big and bulky and requires some time for reconstruction. So I'm going to talk about a couple of the areas that we've worked on in my lab, and the first being optical coherence tomography. If you're not familiar with optical coherence tomography, it's the optical analog to ultrasound. So in ultrasound, you put in a sound pulse, and you wait for that sound wave to reflect back from acoustic index mismatches, and basically you just do pulse echo. You put in the pulse, you listen for it, for how long it took to come back to you, you know how deep that reflection was. By how strong of the pulse came back to you, you know something about the magnitude of the acoustic index mismatch. Well, we do the same thing with light, except light travels too fast, really, to do pulse echo, at least with current instrumentation. And so we use an interferometric method to be able to time the light. But basically, it gives you images of this type. It's outstanding for mapping the microstructure of tissue, tens of micron scales. And it's really robust. It's really simple, fairly low cost. And you can get images like this. You can see the scales on these. You know, this is only 0.5 millimeter deep. This is actually a mouse colonoscopy image. We're looking through the colon wall of the mouse. We can start seeing little fine structures that are on the order of just a couple of tens of microns deep. We can detect precancers. They show up as big masses. We can do all kinds of things with OCT. So one of the first things we do when we're taking a look at a new technique and a new medical problem is just do a feasibility study. I mean, is there any hope? Is there any contrast here? So one of the first things that we did, actually together with Dr. Dimitro and Dr. Utzinger, is to get ovarian biopsy samples and image them with our respective optical imaging modalities. And here's what we came up with. These are cross-sectional images. So we're looking from the surface of the ovary into the ovary. And so here's a follicular cyst. You see it's pretty homogeneous. There's some areas of greater attenuation, probably due to some old structures in the ovary. Compared to endometriosis, which has a very rough surface and some strange, unusual, not roundish shaped holes in it. Endometriosis being a benign condition, or not life-threatening, but it can cause a lot of pain and discomfort. Whereas these two are cancer specimens. And we see just areas of odd-looking light and dark areas. This one almost looks like it's sitting on top of something that's more normal. This one just basically being necrotic tissue all the way through. So you do 20 patients. You look at the stuff and you go, yep, it looks like there's some differences between the normals and the abnormals. But you can't, you can't really tell what the diagnostic value is going to be from a small study like this. Oh, I apologize for that not being on there. These are all 1.5 millimeters deep in this direction by 4 millimeters wide. So this has been an iterative process where we've looked at the technology evolving at the same time our understanding of the disease is evolving at the same time we're trying to run trials. So this is really interesting where you have this confluence of technology and medical understanding coming together. And really that's nice, hand in hand. They help feed each other. So one of the things we've continued to do since then is evolve the technology. So now instead of just getting a single depth slice, we can get three-dimensional volumes. And so I'm going to show you examples. These are actually of mouse ovaries, because they're sometimes a little easier to come by, and we can manipulate a model to get cancers of the type that we want to image. And so what we're doing now is we're kind of virtually slicing through the ovary from the top down. So rather than cross-sectional images, these are en face images. We could have sliced it the other way if we wanted to. Just got this done for this one. And we can see that when you can get three-dimensional information, you get not necessarily any better resolution, but you get more information in that you can see, oh yeah, that little dark spot I saw is actually a follicular cyst, because I can see how it opens up and then closes back down as I go deeper and deeper in the ovary. So we were able to take a look at what you could see three-dimensionally with normals as compared to three-dimensionally with cancers. And these bright lines are because we had a cover slip overlying it, so you're seeing the large index of refraction mismatch between the glass and the tissue. But I hope, even to somebody who hasn't spent a couple of, almost 2 decades now staring at these black and white images, that you can see that these two images look very different. The patterns inside of them are different, and we can get a lot of information from three-dimensional imaging. One of the other things we've worked on is, can you push OCT down to microscopic resolution? Typically, it's tens of microns. A cell is maybe 10 microns. So you really need about 2-micron resolution before you can claim that you have cellular resolution. And typically, OCT systems don't have that. But if you really work hard at the optics, you can come up with what we call optical coherence microscopy, which just simply gives you higher resolution. So we haven't gotten the rapid three-dimensional acquisition of high-resolution images yet. But if you look at this whole field of view now is smaller. It's about 1 millimeter wide. But all of a sudden, we can start seeing all these little tiny dark dots. And if we compare them to the gold standard histological section, which is where you take tissue, you slice it really thin, and you stain it, we can see that these little dark dots here correspond to the purple dots here, which are all cell nuclei. So we can actually get down to cellular resolution if we want. Okay, this is instrumentation that all of a sudden becomes slower and more complex. So whether it's applicable to in vivo or even necessary for us to see this level of detail in vivo is something that we still need to work out. But we know we can do it. Also, we took an example looking at the fallopian tubes. This is about the time we realized that we should be looking at fallopian tubes too. So here's the mouse fallopian tubes are a little different than the humans, but basically, sure, we can see the structures there too, imaging from the outside through the tube. And the OCT images actually end up looking an awful lot like the gold standard histological sections, which is really, really very nice since physicians are used to looking at stuff like this. And they'd like to be able to see that completely in vivo and completely non-destructively. So I want to move on to another one we've taken a look at, which is multiphoton microscopy. Now, probably most of you in here are familiar with the principles of multiphoton microscopy. Basically, what we're going to do is we're going to squeeze all the photons temporally and spatially. So you use a high NA objective. The one we have is a 0.95 NA, and very short pulses in the order of 100 femtoseconds or so. And you end up with a situation where you can get nonlinear effects. And you can get many different nonlinear effects, but two of the most common that you get are 2-photon excited fluorescence, where you have a molecule that absorbs 2 photons almost simultaneously, and therefore views it as a single photon at twice the frequency. And so when you have fluorescence then from that molecule, it actually ends up being at a wavelength that's shorter than the excitation wavelength. This is great because you can go in with something like 800 nanometer light, near infrared light, which can penetrate pretty deeply into tissue and causes little damage. And yet you can excite those interesting biological fluorophores that tend to have excitations in the less than 500 nanometer range. So that happens, and we've got some examples of 2-photon excited fluorescence images over here, where we're seeing, actually, I like this one because that wiggly band around there is the elastin around a blood vessel. It looks like a piece of elastic. And this image just shows a whole bunch of fluorescence that we were trying for the longest time to figure out what it was. It turns out that it's called lipofuscin, which is just basically a garbage product left over from cellular metabolism that your body can never break down. So it just builds up and builds up and builds up. So we all become more fluorescent with age. The other phenomena that can happen is called second harmonic generation, where 2 photons combine during a scattering event. And so what you end up with is one scattered photon that's at exactly twice the frequency. Both of these, this is an example over here. This is really good for looking at collagen structure. So this wispy structure that you see here is a normal network of collagen fibers. What we're seeing over here is a pathological specimen where those fibers are no longer the nice wispy network that you see in normal, but instead have become tangled and irregular.
Could I ask, guess you get the resolution from the intensity thresholding. It turns on, it's not on because it's not working.
Right. So you get a higher resolution than you would from a single photon technique because not only do you have your focal volume, but your probability of these nonlinear events is only at the most high intensity portion of that. And then the other nice thing is that basically you've only excited one very small volume in the tissue. So if you could put an integrating sphere around the tissue and collect every photon that came out, you know where it came from.
Would it help to go to higher photon or like 3 photon or 4 photon?
Yes, and as a matter of fact, I think there are a few here in the college who are working on 3 photon techniques. Your probability of those events occurring goes down very quickly. So you need higher and higher intensities, and eventually you reach a damage threshold of the tissue. But you could go to longer wavelengths, which will also help you to a point. The minimum, maybe 1,300. You get even less absorption. Eventually, if you get much longer than that, you start running into water absorption. Yeah, but the setup we have, which is shown right here, which is a custom-built system with a Lavision Biotech head on it, and the whole femtosecond laser is back behind the curtain there. We can only get 2 photon phenomena with this system. We just don't have the peak power. So we wanted to show, can you do live imaging with multiphoton microscopy? You typically think of multiphoton microscopy as being very large setups with highly complex, expensive instrumentation. But there are folks, including here in the Optical Sciences Center, who are working on the laser systems that we'll need in order to make these types of things more feasible in the future. So we wanted to show whether or not it was possible to even do this. So we took the multiphoton microscope we have here, and we actually rigged it up to do live imaging on a mouse, and which means you have to bring in the anesthesia machine, and you have to have warming, and you have to have a sterile surgical field. So the close-up is shown here, where we've actually lifted the ovary, which is just a very small piece of tissue right in there, gently removed it out of the body, fixed it in place, and we brought what looks like a massive microscope objective down to it. So, and yes, it works. It actually works quite well. So the engineering challenge will be to take this whole massive, instrument that sits on a 4 by 8 foot optical table and turn it into something that we could take into the operating room. When we do those types of studies, we see some really interesting results. So what I'm showing here is the 2 photon excited fluorescence across here and the second harmonic generation across the bottom as a function of time. So this was the same mouse from, adult to fairly aged for a mouse. And if you look at the 2 photon excited fluorescence, you see that you start seeing more and more fluorescence. And indeed, if we zoom in on that, you can see that you go from almost none to a lot of these, garbage lipopigment type molecules. That's just normal aging. If we look at the second harmonic generation down here, we see, these are in vivo images, so they're not always full field, beautiful over time, every single one. But we see that we have some nice fibers here. Here you get this is breathing artifact that's showing up here. And the final one. But if we zoom in on each of these, we can see we have this nice wispy collagen network. Again, image quality is not as good here, but you can still see it, and you still see it at the end. The collagen structure has really not changed much over time. This is normal. Let's compare this to an animal that's developing disease. And in this case, it's tubular hyperplasia, which is not a malignant cancer, but it's still an abnormality. Again, we see the same thing with the 2 photon excited fluorescence with an increase in fluorescence, and actually you get a lot of fluorescence up at the top. And so why would we have more in a hyperplasia? Hyper meaning much, and plasia being shape. So we're getting a lot of changes here, a lot of activity in the cells. Well, if you have a byproduct of metabolism that you can't get rid of and is fluorescent, if you have a more metabolically active tissue, you're going to get more and more fluorescence. So that's what's happening here. As this tumor is developing, the tissue is becoming very highly fluorescent. And so we can zoom in and we can just see these huge, massive globules full of lipopigments. If we look down at the second harmonic generation, I think you can already see that we're going from the thin, wispy structures here. This isn't such a good image, but it's occurring here too, but to something that looks very much different at the end point. And so we can tell that the second harmonic generation signal actually will give you a lot of information. There's something wrong with the tissue here. That collagen structure is not normal. So I think we were pretty excited with the results of this. The challenge with multiphoton microscopy, again, will be making it something that's suitable for in vivo because it's so much more of a complex system. And also, your field of view is very small. These are 700 by 700 micron images, so you can't get as much in. So you think about, the old idea of how do you find the cup at a golf course if you're out there looking through a straw. You have to look around. So you could end up with a similar problem here, where we have a technique that gives beautiful images, really gives a lot of information about progression of disease, but has an extremely small field of view. So these images, what we did here is we took stacks of images from the surface, all the way down, so maybe 15 to 20 images, and it would take a couple of minutes to do. I don't think that's a fundamental limitation. That's mostly based on the instrumentation that we had. We were also extremely conservative with the power that we put on the tissue, so we had the acquisition time be longer. So I think you could get this down to near real time if you cranked up the power and had a better collection system.
The SHG, is that happening in the tissue?
Yes. So you actually have the collagen fibril structure itself is the type of structure that will take these two photons and scatter them into the one. So there are other things in the tissue that will show up with the second harmonic generation signal, but collagen is by far the most dominant. All right, so one more that we've done in my lab, and that's laser-induced fluorescence. So here, you just basically, it's a very simple technique. You dump light on the tissue. There's these different fluorophores of different kinds. There's several different molecules in the body that will fluoresce, and I've lifted some of them down here. Some of them are amino acids, metabolic cofactors, structural proteins, porphyrins. We don't have chlorophyll in our body, but plants do. And then, they will fluoresce with different, characteristic emission spectra. And you can basically collect that light that came back. You can disperse it with a spectrograph. And what you end up with is a fingerprint of the tissue. That's a superposition of the emission spectra of all these fluorophores, weighted by how deep they are in the tissue and weighted by the instrument response. And so we thought, well, gosh, wouldn't it be great if cancerous tissue has a different composition than normal tissue? Maybe we can just tell by the fluorescent spectra whether tissue is normal or cancerous. And you can, just not with perfect sensitivity and specificity. So we did a study on rat ovaries that we knew exactly the diagnosis that they had, all the way from a complete normal to some that had been treated but were not yet cancerous, down to a tumor-type tissue. And you can see that you go from the normal spectra here, kind of stepwise through these different levels of abnormality, finally to the tumor. And the average spectra actually look quite a bit different. But by the time you put the error bars on them and you actually run a sensitivity specificity analysis, it's not that great. Although, frankly, I'll tell you that it's better than a lot of medical tests that are out there right now. But if the bar is you're trying to determine whether or not a fallopian tube or an ovary is starting to become cancerous, and if the woman contracts cancer, she's probably going to die, you had darn well better be very, very, very sensitive. So it by itself, this technique wouldn't be sufficient. If you want to, rather than dispersing the spectra, actually just take a snapshot and accept a band. So we're looking at spatial information, fluorescence information here rather than spectral. And you want to do something like, rather than looking at the autofluorescence of the tissue, why don't we do a targeted fluorophore a targeted exogenous agent that we put onto the tissue that will bind to a certain receptor of interest, then you can start getting some really very interesting results. Now, I threw this in for colon because we don't have any ovary images. But if you look at vascular endothelial growth factor receptor, which is upregulated or more abundant when there are blood vessels growing in, and you need to have blood in to support a cancer, then all of a sudden you can start seeing tumors, which are the things in the dark boxes, all of a sudden start lighting up. And what I found really intriguing is that some of the tumors, whether they be large or smaller, light up a lot, and other tumors don't light up as much. Well, so what we hope that means is that this tumor and that tumor are maybe more rapidly growing, more aggressive. They're recruiting more blood vessels than this one over here. So if we have a technique that's non-destructive, we can follow this over time and test whether or not that hypothesis is true, and we're still working on that. But basically, one of the things I wanted to show you is that we can, with these fluorescence techniques, use exogenous agents, which give you really some very good information on not only that there's a tumor there, but probably some information about its function. Now I'm going to show an example of, this is actually Dr. Orzotzinger's system that he's built called Ratiometric Multispectral Imaging, and I put it up here because we're working together now on a grant, and we're using his instrument together with my optical coherence tomography to look at some ovary tissues. So just briefly, this is another type of fluorescence imaging whereby we can take a whole bunch of different wavelengths, we just pick them out with a filter wheel, put them on the tissue, which sits down here. The tissue either reflects light or you have fluorescent light that comes back up, goes through another filter wheel, and is imaged by a camera. So what you can get is a whole bunch of images of either reflectance or fluorescence at different excitation wavelengths and different emission bands, which gives you a lot of really interesting information. But even more fun, if you take those images and you put them together, you know, divide one by the other or subtract one from the other or multiply them together, you can maybe even get more information or higher contrast or different alternative forms of contrast. So far we've tried that out just on, these are human ex vivo biopsies. Here's the white light picture. So we have 2 samples of ovary and 2 samples of fallopian tube. And if you just look at just plain old, this is emission when you excite with 280, so UV light. And we think we're mostly looking at tryptophan here. Here's 320 nanometer light. We think we're mostly looking at collagen. Interesting, this one doesn't show up hardly at all. Must not be a whole lot of collagen in that sample. If you go out in longer and longer wavelengths, you can see the fluorescence that you get. These are ratiometric images where you start taking these images and combining them in different ways. And just all I want to show is it's interesting how you get different forms of contrast, things show up, you lose all your specular reflection, and you can actually, we don't have enough samples to know whether or not we can tell diseased versus normal with this technique in ovary. It's been shown that it works in the colon, and we think that this has a lot of promise. So we're working on that right now. Okay, so I've talked a lot about different techniques we can use. And so we've shown that all of these are feasible. They look like they're interesting. We haven't done the big massive trials on many of them. We've done them on animals, and we're pretty sure that we can show some statistics there to say that these are good. We don't have the numbers on people yet. But if we're going to look forward, we really have to think about how are we going to implement this in vivo and how are we going to implement it in a way that's acceptable to the patients. So if you look at, you know, here's the uterus, here, the fallopian tubes coming off, and the 2 ovaries, you know, how can you get there? So the first way, which I've already discussed, is laparoscopically, where you make an incision in the belly, you put the probe in, and it's great because you've got lots of room in there. You typically have 4 or so incisions in there, so you've got a big camera. You can see what's going on. You can put graspers in there. You can put your probe in there. You can take the graspers. You can take a hold of the tissue, and you can move it over to your probe. So it's not, I don't want to simplify it. It still requires great skill on the part of the surgeon to be able to do this, but it's fairly easy in that you can see what you're doing and you've got plenty of room to work with. You can get a large diameter probe, maybe up to 8 millimeters, which is huge for what we typically work with. How do you access the fallopian tubes? Actually, Ratiometric has a really clever device where the end of this articulates, so you can actually stick it in the end of the fallopian tubes. So with this technique, you can access the ovaries and you can access the very distal part of the fallopian tubes. Are there alternative ways that we can get there? Well, another way that you might be able to get there, which is a little less invasive, is to do transvaginal imaging. And this is actually done right now for in vitro fertilization purposes when they have to harvest the eggs. So they come in through the vagina with an ultrasound probe. So you can't quite see what you're doing in there, but at least you have an ultrasound image. You have a needle probe that goes along with it, pierces through the wall right here just below the cervix, which is pretty thin. And then you can extend through it a little probe that maybe had some sort of articulating end on it. So we can use a flexible probe. We can probably, to the extent that we can manipulate this probe all around in this area, into the fallopian tubes around the ovary, you have much tighter diameter constraints and much poorer guidance. And you have a lot less room to work in because you've come through one tiny hole rather than having the whole space of the abdomen to work in. All right, but there's no incision to heal. I mean, this is just a small puncture through the wall of the vagina that will just heal on its own. You don't have to worry about it. So it's much less invasive. Is there another way to get there? Well, there actually is a natural orifice all the way through to the ovary, and you wouldn't have to make any incisions or punctures at all. And the idea would be if you actually went through the fallopian tubes. So there are right now hysteroscopes, which is what I've represented here by this dark line, that can go all the way into the uterus, and then you would have to snake a very small diameter probe, and in reality it would probably be a little stiffer and actually straighten out the fallopian tube rather than following along with it quite so well, which could go all the way through the fallopian tube and back out through the ovaries. This requires a flexible probe, and it's extremely small diameter. There's no FDA-approved scope for imaging the fallopian tubes in the United States right now. There was one that was for a while was used in Europe. It was 0.6 millimeters in diameter. So we're talking very small here, and it would have to be very flexible. And you don't essentially get no guidance except what your imaging system itself can provide. You could use external ultrasound. Your resolution would be pretty poor.
Is that still used in Europe, or you said it was in Europe? Is it still?
It was approved in Europe. I don't think it's caught on a whole lot, but for looking for blockages, it's for fertility purposes really. They're trying to they basically can use the scope to kind of ram through blockages in the fallopian tubes and open them back up. Yeah. So what technology should be pursued? And of course, I haven't put other ones on here that other people are looking at, but just basically things we worked on in my lab. Well, OCT, multiphoton microscopy, fluorescence imaging, laparoscopic, transvaginal, or transtubal. So laparoscopic OCT, we've already done it. Transvaginal, people have developed needle probes for OCT, not for imaging the ovaries. But we think probably technologically we could get there. Transtubal, I think it's possible. OCT can, really doesn't have to be any larger than a single node fiber, 150, 200 microns in diameter. That ought to be possible. Multiphoton microscopy. In laparoscopic, you could do it right now. It's difficult to get those femtosecond pulses through a long fiber, is really the limitation there. Although I think that limitation will go away. But right now, you could probably do it laparoscopically with bulk relay optics. But right now, we'd have to haul that big, huge laser into the operating room, which probably isn't quite so feasible right now. Again, it'd be difficult to do transvaginally and transtubal right now. So we're going to kind of eliminate that one for the moment. But I think this is a case where we need technology to catch up. And then we can go after more applications. Fluorescence imaging, really a lot of opportunities. Bulk relay, fiber bundle, scanning fiber. Once you get down to the transtubal, you have so little room that you don't actually have room for a scanning mechanism. So you'd probably want to use a very small fiber bundle, which do exist. So we're gonna look at those two. And right now, one of the things we're doing in the lab is using those two right now in various ways. I just wanted to show up now examples So the one that we've done is laparoscopic imaging. So I'll show you the most about it. And then when we start thinking about transvaginal or transtubal, then they become progressively less and less well-developed ideas. But just to tell you what I'm thinking of, this is the system that we built for laparoscopic OCT imaging. And so we just put everything on a cart. It fits all nicely on a cart. In fact, nowadays we wouldn't even use a tower. We'd just use a laptop. It'd get even smaller. And then this is what went in the patient. So here's the long part that goes from the outside and reaches into the ovaries. This was about 4.6 millimeters in diameter. And actually, we would have liked it to have been smaller. But we were told in order to fit the current systems that they had, the ports that they put into the belly, they wanted it larger. Not the greatest resolution in the world because we used basically, extra things we had lying around in order to build this system, but not bad either. And the probe handle out here a little larger. What this has is there's a fiber that goes all the way to the end. There's a little miniature grin lens and a little miniature right angle prism that direct the light out the window here, which you can see. And then inside of the handle was a linear motor that just kind of pulled the fiber back. And so you took images in the tissue as you pulled it back. That's how you built up a two-dimensional image. Here's a picture of it being used in the operating room. And so that's it right there in our physician, Dr. Kenneth Hatch's right hand. He's got the instrument there. Most of it's going in the belly. She's not pregnant or fat. That's just what they do with laparoscopic imaging. They inflate the belly with carbon dioxide, so you have room to look in there. And if you see the camera view, there's the ovary there, the right thing. And this is what I was talking about, having room to manipulate in there, having a pair of graspers that can basically take the ovary and move it to the probe and image. And we got images that I think are not pretty darn good for doing something in vivo under pressure in a system where you have some more technical constraints. And we were able to show, just like we did with the ex vivo study, that you get normal is actually pretty boring looking. You can get these benign conditions, cysts and cystadenomas, and then once you start getting to malignant tissue, things start looking ugly. So these are the OCT images in black and white, and then the gold standard histology underneath them, which confirmed the diagnosis. So I think, we're pretty happy with that. For high resolution, we haven't built anything that we can put yet in patients, but we did figure out how to take our ultra-high resolution OCT or optical coherence microscopy and put it into a system that could be used for laparoscopic imaging. We would just need to replicate this relay system a few more times to get that end longer and longer and longer. And so this just shows the mechanical and optical layout here, and then a ray trace through here. Basically, we're just, these are scan lenses, there's a scanning system here, a whole relay system, and then a little final objective at the end. So we didn't get the grant to make this long and go in patients, so we never did it. But aside from this being a rather expensive way to go with all these custom optics, it actually worked quite well. So that's it for laparoscopic. So we started thinking about if you were going to go transvaginal, how would you think about doing it? We need something that's smaller. And we think that OCT is good, but probably we'd like to maybe do both those modalities at the same time. And how could we do this? So the next couple of things we have up here are just concepts. So if we want a semi-rigid probe here, and we want to be able to do OCT and fluorescence imaging, how might we do that? Well, here's just an OCT system, which is pretty simple. We've basically just got the source, half the light will go into the sample, come back, and then combine with a reference mirror here at the detector. So just a basic diagram of an OCT system. If we want to use a targeted dye, we can use dyes that fluoresce in the near infrared, which is good because then you don't actually have all that background fluorescence from the normal tissues. So we could combine these two wavelengths in the wavelength division multiplexer, put it through into a dual core, dual clad fiber. And so we combine them and we run both the excitation light and the OCT into a single mode core of a dual clad fiber. And then what will happen is this light will shine on the tissue, the tissue will fluoresce, the OCT light will come back, the tissue will fluoresce, the fluorescence light will come back, and that will be traveling both through the core and the inner cladding. The reason for using the dual clad fiber is that the inner cladding then can have a larger diameter and a larger numerical aperture, so you can actually collect more light, collect more fluorescence. You're always photon starved in fluorescence. And so that both comes back, but what will happen here is that only the OCT light and any reflected excitation light will be efficiently coupled back into the core of the single mode fiber. The fluorescence light is picked off here with the beam splitter and taken to a PMT. So this is a way, so essentially we've got a very thin diameter fiber here now that is capable of carrying both modalities, and it's just one fiber. So this is a good way of making things small. The problem we have is that we have to scan somehow now if we only have a single fiber. And so how do you do that? Well, there's probably all different kinds of ways that you could think about doing it. But one of the ways that you can make small enough, sub 2 millimeters in diameter, would be to use a little piezo tube and actually wiggle that fiber at resonance so that you deflected the fiber across the back of some sort of imaging lens system. So that's one way of doing it. And this idea here is not completely novel. Other people have suggested doing things like this before. The idea of making something like this and putting it into a needle probe and using it for imaging the ovaries would be just another level of challenge. Okay. Now we're getting really conceptual. See, I'm just giving you the latest off the whiteboard idea here of how would you go do OCT and some sort of fluorescence imaging system in a 0.6 millimeter diameter package. Is it even feasible? And it turns out it is. You can get a 300 micron diameter, 3,000 element fiber bundle. So you can do imaging. You can put in a single mode fiber for OCT. Problem with fiber bundles that exist that are that small is they can't carry UV light. So if you want to do UV excitation, it won't work. So if you want to do UV excitation, if you want to do red, you could probably pump the red down the fiber bundle. But if you want to do autofluorescence and that ratiometric multispectral fluorescence technique, you need a separate, maybe 100 micron core diameter. I think I've lost my, it's okay. And then you also need some way of steering it. So you need a channel, maybe for a nitinol guide wire, something that you can use that will, you can push and pull it and push and pull the guide wire in and out to make the endoscope itself turn and go down the fallopian tubes and curl around to access the ovaries. And it turns out, yes, you can get that all together in less than 0.6 microns. How do you scan? Well, there's no room for a piezo tube or anything to scan in here. So if you want to scan, you're actually going to need to send the light out either perpendicularly or at an angle and actually turn and twist the fiber in order to scan that way for the OCT. Since we have the fiber bundle for the multispectral fluorescence imaging, then that's not, you don't need to scan for that. But to scan for the OCT, you'd actually have to spin or translate or something the fiber. But that's not all that different than we did in our original OCT in vivo study where we actually translated the fiber. So we think that's probably doable. So we'll work and see if we can make something like that come to life. So what do we need to do from here? I think we've shown that their optical techniques show promise for early detection of ovarian cancer, and that's still where we are. You know, we're at the, it shows promise. We haven't proven anything. We're really trying to push the state of the art right now here to get to less and less invasive techniques, maybe even going through a natural orifice. And maybe that would make it possible so that high-risk women in the future could just come in for their yearly ovarian cancer screening just like they come in for yearly cervical cancer screening. And many optical techniques are possible, which is best is still to be determined. We need to find out. Hopefully it'll turn out that several of these techniques are useful. Really where we have to go is that the true bar for success is showing that optical imaging extends life. That's really what we want to do. It doesn't matter whether it detects cancer or can tell the difference between normal and abnormal or anything like that. We have to be able to implement it in a way that's acceptable to patients, acceptable to physicians, will be commercially accessible, will get out there in the marketplace, will be used, and actually end up extending life. So I think I have something to do for the rest of my career. So anyway, I just want to thank all the people who've worked with me and some of the current and former students who have worked on this project and my funding agencies. So thank you very much.
We have time for questions.
Is it definitive that the cancer would start in the fallopian tubes, or?
People are still debating that.